This presentation will be a review of the anatomy and biomechanics of the mid-cervical spine. The cervical vertebrae have some unique features which we should consider when and treating this region. If you take a look at the vertebra on the right top corner, you can see from its shape that the superior surface is a U-shape surface, or a female surface, which houses the vertebra from the level above. In the anterior-posterior plane, it is more of a male surface, and you can see this inferior anterior projection of the vertebral body, which will then, this lip that will sit over top of the vertebra below. The U shape is formed because of the uncinate process, which is number 11, and we will talk more about the development of this process as well as the U joint that is located here. We also note that the cervical spine has bifid spinous processes, which we often can palpate posteriorly. An additional unique feature would be number 7, which is the intertransverse foramen, which houses the vertebral artery. The transverse process is short and has 2 projections: anterior, which is number 6, the anterior tubercle, which we will use to palpate in the anterior aspect of the cervical spine during assessment. Posterior tubercle is behind that. There's a groove that sits, or a curve shape that sits between these 2 tubercles, and if you look over at the complete unit on the left, you can see this groove between the anterior and the posterior tubercle, which forms a gutter through which the nerve root will exit at that level. The nerve root in this gutter is also adhered, the dura of the nerve root is adhered in this location. The foramen in the cervical spine, which is labeled 10, is triangular shape and houses the cervical cord. Also of note is the size of the surface area of the facet, labeled number 3, as compared to the surface area of the vertebral body, labeled number 8. If you take a look at the size of these, you can see that the 2 facets added together are almost equal to the surface area of the vertebral body. Also, the orientation of these facets allows for some weight-bearing function, and in the cervical spine we should think of 3 weight-bearing columns rather than just the anterior vertebral body. When you look on the left at the complete cervical unit, you can again see the arrangement of the U joint and the U-shaped superior aspect of the vertebra, excepting the vertebra from the level above. The zygapophyseal surfaces, labeled number 3, are variable in shape. From C3 to C6, they are generally planar, more concave posteriorly at C7 and T1. And in the upper cervical spine, they tend to be a bit more circular, whereas lower in the cervical spine, they are elongated transversely. Remember, as we mentioned, that these facets are considered a part of the weight-bearing column of the cervical spine, and this may be potentially why there are so many degenerative changes in the cervical spine. As well as being different shape, the articular surfaces are also variable in their orientation, slightly variable in their orientation. C4-5 and C5-6 tend to be generally more mobile because they face more posterolateral. They tend to be oval or circular, and also in this area there's quite a bit of transitional or asymmetrical changes in the facets themselves, and this tends to lead toward more degenerative changes in this region of the spine. The actual Z joint orientation in space can be observed on the left-hand side column. You can see at the top the AA joint is almost completely horizontal, and then when you move down onto C2, 3, C3, 4, and C4, 5, they are oriented more toward between the horizontal and vertical plane. On average, this orientation would be about 45 degrees, but it starts in the upper cervical spine more as 60 degrees from the vertical, and as you get down to the lower, more toward 30 degrees from the vertical. So if you look at the schematic diagram on the right-hand side, you will see that if you draw a line along the plane of each of these joints, they will tend to run up and anterior, and we talk often about the plane of the joint intersecting through the eye. So if you think of that sort of orientation as you're assessing and treating these joints, you will be close toward the plane of the joint. But again, you should feel for that specifically as you assess. Meniscoid structures are common in the mid-cervical spine, type 1 to type 3. And they exist in about 77% of the cervical joints that were observed. You can see that the meniscoid itself has a free edge that transverses into the surface of the joint itself and attaches in the periphery to the joint capsule. There are also capsular rims that are just small folds of the capsule surface itself. You can see in the bottom diagram on the right that the meniscoid itself can project well into the joint cavity itself, and you could see how this could become injured with a compression joint injury or with a translational type injury, and that it could also be a potential block to movement in the cervical spine. A study by Yu et al. Looked at the changes in the meniscoid structures with aging and with degeneration. You can see on the left-hand side at the bottom where the arrows are that there is a healthy, small projection of a meniscoid into the anterior aspect of this very healthy facet joint. You can see the distinct articular cartilage and the healthy surfaces. If you look at the arrow on the right of this lower diagram, you can see that there's some degenerative changing, there's some osteophytic lipping that you can see along the edge of the bone, and you can see that the meniscoid structure has become enlarged to fill in the space that's created by this degenerative process. Yu et al. Felt that the meniscoid function is to restabilize a joint as it degenerates. But as you can see, there are definitely meniscoid structures evident in healthy young cervical spines. So let's look at the capsule. The capsule is a strong structure, but it's lax to allow the motion that's required in the cervical spine. It's reinforced by both the ligamentum flavum as well as muscle posteriorly. And it definitely is innervated with a very large receptor field. There's muscle attachment into the posterior aspect of the capsule. 22.4% of the capsule surface has muscle insertion. The deep multifidus originates from the posterior aspect of the capsule. A study by Winkelstein et al. Found that the force of contraction along with motion that would occur during a WOD injury would be enough to partially rupture the joint capsule. The cervical disc is very different from a lumbar disc, and we should not think of this as being a similar structure. The morphology of the cervical disc has not been studied in as much detail as the lumbar spine, but we cannot just extrapolate the information from the lumbar studies to the cervical spine. We do know that the cervical disc is innervated. There are several studies that have shown that, and Cloward's study injected the posterior aspect of the disc and found referral of pain into the scapular area. So we need to make sure that any time we're looking at someone with interscapular pain that we are also assessing in detail the cervical spine. The nucleus is very different in the cervical spine than in the lumbar spine. It's only 25% of the disc in the young cervical disc, as compared to 50% in the lumbar spine. It is become fibrocartilaginous by the mid-teens, whereas in the lumbar spine this is more toward the late 30s. There's higher levels of collagen within the nucleus and the disc in the cervical spine at all ages. And here you can see on the right-hand side the arrow pointing to a very small area of nucleus. You can see that this is an infant specimen because there's no U-joint projection. It's a very flat surface, and you can see some growth plates here. The annulus is also quite different, not as well developed as in the lumbar spine. Anteriorly, there definitely is an annulus structure with deep intermediate and transitional fibers, and the more superficial aspect of this is reinforced by deep and alar fibers of the anterior longitudinal ligament. Now, posteriorly, it's much more deficient. There's only one set of thin vertical fibers of annulus on the posterior aspect, but this would be further reinforced by the posterior longitudinal ligament. Laterally, there is a thin periosteofascial layer that covers the U-joint cleft. So let's look at the uncovertebral joint specifically. If you look at the specimen of 3 years, you can see that the uncinate process has not yet developed. This begins to develop and is definitely present by the end of the first decade. These uncinate projections are in the posterolateral corner of the vertebra. Clefting will start to occur in the lateral disc by the end of the second decade. This is seen, and this is as a normal aging process, a normal developmental process, and occurs in healthy disc tissue. As we age, this penetrates more medially from each side as a response to rotation, and as we age, this separation often occurs across the whole posterior aspect of the disc, dividing the disc into 2 separate portions at the back. Here you see an anatomical preparation. Again, you can tell that this is fairly healthy, young hydrated disc with no osteophytic formation in the joint itself, but you can see the lateral clefting occurring between the superior and inferior aspect of the disc, starting from lateral, projecting in toward medial. In an older specimen, if you look at the posterior aspect, again you see the thin vertical annular fibers, but if you remove those, you can often see complete posterior clefting across the back, half to 2/3 of the vertebral disc. There are several studies that look at age changes versus degenerative processes in the cervical spine, and sometimes it is hard to differentiate what is normal age changes as compared to what is a pathological osteoarthritic joint. If you look on the left at the 10-year-old, and you can see where the arrows are here, that you've got very healthy articular cartilage, and there's no bony exostosis or lipping occurring at the anterior posterior aspects of the joint. If you look over on the right to the 37-year-old and you look at the top joint, C2-3, you can see both anteriorly and posteriorly there are projections of bone or osteophytes developing in in both aspects of the vertebra. In the joint lower down, you can also see that the articular cartilage is being worn down at that joint. Again, if you look on the left, you can see the facet joint is posteriorly, but if you look at the posterolateral corner just anterior to the intervertebral foramen, this is the uncinate process projection, and you can see some degenerative changes, particularly in the second to bottom joint, where there's a lot of posterolateral lipping and bone growth in that area. You can see that both at that level and the level above that it decreases the available space for the intervertebral foramen. This would also affect, if you look on the right side diagram, the area where the U joint is projects right next to the vertebral artery that's ascending along in the foramen transversarium. You will often see, well, you can see on this specimen, the clefting going right across each joint level, right through the posterior aspect of the disc. But you can also see at some of the levels where the U joint has actually become a little bit more flattened and projects out more laterally, which would crowd some of the neuro and vascular structures in that cervical spine. Now, what about injury? One of the most common things we see when we're treating cervical spines are people that have suffered a WOD type of injury. We know that the dorsal shear forces are greater than the vertical shear forces at the time of injury. If you look at the ventral aspect of the facet, you will get distraction type forces and tension injuries to the capsule, and in this anterior aspect is also where you will get rim lesions. Dorsally will be more of a compression force and pinching of the capsule and meniscoid structures posteriorly, and you also here will get some of your subchondral bone injuries. So anterior rim lesions have been documented in WOD patients. If you look at the lower left-hand corner, you can see that this is a fairly healthy specimen with good intervertebral disc height, good bony configuration above and below. If you look at the anterior aspect, where the ventral distraction forces might put a traction type of stretch on this intervertebral disc, you can see that the disc itself has been peeled away from the end plate below, and you can see a blood-filled area just above that. On the right upper corner, you can see another specimen that is a little bit older. The shape of the cervical disc has modified over time. You can see a little bit of posterior lipping at this level. You can also see the clefting that comes across in the posterior aspect of that vertebra, of that intervertebral disc, at least a half, if not 2/3 of the way through into that intervertebral disc. You can see that there is also an anterior rim lesion where the disc has been peeled away from the end plate, but there also is a posterior rim lesion which can occur. They can occur anywhere along the surface. There's been quite a bit of interest in the literature over the last while trying to compare the results of a WOD injury between male and females. We know from the statistics that more males are involved in motor vehicle accidents, yet more females report neck injury, and that's at a rate of 2-to-1. Females are much more likely to develop chronic WOD, and the incidence of recovery is significantly lower in in females. So why is this? There's a number of reasons that have come up in the research. One is that there is a larger angulation of the S-shaped curve at all levels at the time of impact in females compared to males. There are also greater shear and distraction forces because of this S-shaped curve. Females have a larger dorsal gap in the cartilage, and I'll explain that in a second, as well as thinner articular cartilage on the surface of the bone. There's less muscle attachment into the capsule, which may affect the ability to stabilize either during or restabilize after the accident. And studies have also shown some significant, more significant histological changes in muscle in females as compared to males. The cartilage surface, the cartilage surfaces the bone of the facet in the cervical spine, but at both the anterior and the posterior aspect there is what they call a gap, both ventral and dorsal. And the gaps are larger in the lower levels of the cervical spine. But this dorsal gap tends to be longer or wider in females than in males, and as we mentioned before, the cartilage surface itself is less thick in females. So let's look at the biomechanics of this area, the mid-cervical spine. The mid-cervical spine as a functional unit includes C2 down to the CT junction C7 on T1. If we're assessing the mid-cervical spine, we obviously also have to look at the craniovertebral region, as C2 is really a transitional vertebra that is affected by movement above as well as movement below. There are 3 degrees of freedom of movement in this region of the spine: flexion extension, rotation and side bending, although rotation and side bending are conjunct movements that occur together. For flexion extension, movement is about a transverse axis, and this axis is located in the inferior vertebral body, and it starts more posterior inferior, and as you go further down the spine it moves more anterior and superior, such that at the C6-7 level the axis is almost into the intervertebral disc. This location of the axis will alter the relative amount of translation per angular motion that occurs at a joint. So if you look at C2-3, with its axis being in the posterior inferior aspect of the vertebra below, to achieve the same amount of angular motion, there will be a much greater amount of translation as compared to C4-5, where, because the axis is closer to the moving superior bone, there is relatively less. Now C4-5 still has the largest total amount of anterior-posterior translation, but its amount of angulation is also the largest. But C2-3, because of its location of its axis, has relatively the greatest amount of translation per degree of flexion extension, and that may put a stress on some of the tissues at this level. So if we look at the biomechanics of flexion extension, osteokinematically it's an anterior rotation and an anterior translation. Now if we think about the movements that take place arthrokinematically at the joint itself, we have at the Z joint an anterior superior glide, and at the U joint an anterior glide. If you look at this Z joint motion, and often people will talk about flexion as being opening, and yes, relatively there is an opening or a stretch of the Z joint posteriorly, but there's actually a great deal of compression at the joint in the anterior aspect. So we often talk about flexion as being opening, and it indeed is opening for the intervertebral foramen, but for the Z joint itself, it might not be the best term to use, although we tend to fall back on that. For extension, we're now thinking about posterior rotation with a posterior translation, and the arthrokinematics are exactly opposite. The posterior inferior glide occurs at the Z joint, and at the U joint there's also a posterior glide. Again, here, if you look and if you were to think about this as closing, yes, there are more compression forces, particularly in the posterior aspect of the joint during extension, but the anterior aspect of the joint actually does open. Definitely, there is closing of the intervertebral foramen on extension. So we should probably think of rotation side flexion as being a combined movement in the mid-cervical spine. And the axis of this combined movement is oblique, and it would be considered to be perpendicular to the plane of the Z joint. So if the plane of the Z joint is coming up on this angle, then the axis of motion would be perpendicular to that. We know that rotation and side bending couple ipsilateral in all positions, regardless of whether we initiate the motion through side bending or rotation. There has been some question about the mechanics of C2-3, in that in some situations we may actually see some contralateral coupling. So arthrokinematically, if we look at the osteokinematic movement of left side bending and left rotation, we know that at the Z joint on the contralateral side to the movement, so the right Z joint will have an anterior superior glide, and the left joint will have a posterior inferior glide. When we look at the vertebra itself in space, we know that as we left rotate and left side bend, that because this is a male surface sitting within the female U-shaped vertebral body, that the lateral translation will occur to the opposite side of which we're moving. So on left side bending, we will translate to the right. At the U joint, the right U joint, you will get a anterior motion for sure, and because of this lateral translation, you'll also get superior motion. On the left UV joint, you will get posterior glide, and you'll also get slight inferior because of the lateral translation of the bone in space. Now if we look at the facet joints again, we know this is an anterior superior motion, but we also will get some medial lateral component. So let's look at the left side first. When we left side bend and left rotate, we go posterior inferior, and it will tend to go medially because of the axis being oblique in the central area. So it will also rotate, it will also move medially. Also, because the whole bone in space is translating to the right, you will have even more of this postero-infero medial motion. If you go on to the right facet, you will see that you get this anterior superior motion, and because you're moving around midline axis, you'll get some medial motion along the surface of that bone, but it will not be as much medial motion because the vertebra at the same time is sliding laterally to the right. So people will talk about this motion as being an antero-supero-lateral motion, and when the head is moving as a full unit in space, that probably that may well be what occurs there. But because if you think of this as sort of a steering wheel with and a circle running around the midline axis, this tendency toward lateral movement is decreased by the tendency for a medial motion at the joint surface. So yes, this is definitely an imp or inferomedial posterior motion. whether or not this is what people will refer to as a SAL movement, superior anterolateral, well, there's some chance that it might actually be somewhat of a SAM movement. So I think we should mainly think about superior antero, posterior inferior, and then feel the motion as to whether or not there's more of a medial or lateral component to it. It's also important to think of the movements of the whole head in space. When we're looking at active movement as compared to when we're doing our PIVMs, with active movement, it is movement of the whole spine as a unit. And functional head movement in space will also include movement of the craniovertebral joints. So in a study by Edmondson, they looked in vivo at functional movements of the head in space. So if you look at rotation and side bending, and if you look first in neutral, your tendency when you rotate is to ipsilateral side flex and to extend. So most people, when they rotate to the right, they will tend to side bend to the right, and they will also tend to extend. And I think that's the pattern that we tend to see most often. And it occurred in 70%. So you have to remember that in 30% of normal subjects, this did not occur. So if you look at side flexion in neutral, when we side bend to the right, we tend to rotate toward the right, and again, we tend to extend, and this occurred in 77% of their subjects. So if we change the starting position and now place the head in either a more retruded or protruded position, and then have the person rotate or side bend, we see different patterns starting to emerge. In protrusion, when you rotate, you still, in 58% of the cases, tend to ipsilateral side bend as well as extend. So the pattern in protrusion is more similar to the pattern in neutral, but you now have 42% of people doing something different. When you retract and you side bend, you still will have the majority of the subjects ipsilateral rotating and extending. There are the two other boxes where the pattern of movement changes dramatically. So if you place the head in retraction and then you rotate, only 35% of people will ipsilateral side bend and extend. And the reason why this is so different is that more often people will flex when they're in that retracted position rather than extend. And we can use that to think about if we want people to avoid an extension motion, then placing them in retraction before they move might keep them more flexed. The other group that showed quite a marked difference was when we side bend in protrusion. So if you jut the chin forward and then side bend to the right, more often subjects did a contralateral rotation rather than ipsilateral rotation. They still tended to extend. So you can see that you can talk about the biomechanics at a single joint level and think about that as we're doing our PIVMs and PAVMs. But what the head does in space is going to be driven by a lot of other factors. And we need to consider that the normal pattern of movement in protrusion is not necessarily ipsilateral, and so if we're not seeing that with our patients, we probably shouldn't be expecting to see it with our patients.